Hello, everyone. Welcome to the Fujifilm Healthcare webinar organized in occasion of the ISUOG Congress. Thank you very much for joining. This is one of our clinical activities we arrange for this Congress. My name is Luca Mastrogirolamo. I'm European Clinical Support Manager for Fujifilm Healthcare in Europe, and I will be your facilitator for this event. Today, we are pleased to have as a panelist of this webinar, Dr. Marc Althuser from Grenoble in France. Dr. Althuser is a gynecologist, he's an ultrasound expert in fetal medicine, and he has a very long expertise in ultrasound. Today, we'll present us a lecture with the title Central Nervous System in High Frequency on the First Trimester with Abdominal Probe. You can place your question to Dr. Althuser on the chat of this platform. So we will be happy to submit them to our panelists to get a reply. So I'm pleased to introduce Dr. Althuser. Thank you very much for joining us. The floor now is yours. Thank you.
Hello, everyone. First of all, I have to apologize for my quite poor English. I'm sorry. Thanks to Fujifilm for giving me the opportunity to talk about transabdominal high-frequency images. We have a long know about high resolution with transvaginal probes. Despite the fact that ultrasound attenuation varies with the square of the frequency, which limits access to uterus contents through the skin, all the images that follow are obtained by a small external 10 MHz probe having good penetration. Here, an 8.5 weeks embryo where we can see the medullary canal while the vertebrae are not yet ossified. It's sharper with high magnification. With an external probe, it's possible to make sweeping movement as here to follow the spine at 12 weeks. Indeed, we know that external probes are much more manageable than endocavitary probes. To illustrate it, the benefit of these probes, a variation on the development of the corpus callosum between 14 and 32 weeks. At 6.5 weeks, we cannot know where the cephalic pole is. But from 7.5 weeks, in sagittal and frontal view, we identify a small anechoic image at one of the embryo's pole, which correspond to the mesencephalic cavity. The mesencephalic cavity is much more visible with high frequency. At 8.5 weeks, the curvature of the cephalic tube is a reality on ultrasound. In this sagittal view, the diencephalic, mesencephalic, and rhombencephalic vesicles are seen in row. In frontal view, the diencephalon in front and rhombencephalon behind. The posterior wide cavity will be the future fourth ventricle. At this age, and in accordance to embryology, the derivatives of the three primitive vesicles are widely communicating. In front, the draft, 4 brain vesicles, future lateral ventricle. At 12 weeks, the telencephalon has flourished and almost covers the brainstem. With an external probe, we find the central ventricular network, but it is better visible with high frequency. The reference cross-section passes through various landmarks. 3 of them are on the central line and 2 are laterals. Let's start with the side marks. On this frontal view, we can observe that the 2 echogenic areas correspond to the base of the 2 choroid plexuses. If the section is higher, we can see the body of the choroid plexuses very well. But in this case, the BPD measurement will be reduced substantially. Now, the front marker. By analogy with the second trimester, one might be tempted to think that it is the cavum septum pellucidum. In reality, CSP does not exist at this age. As we can see in this translation from the vertex to the base, these three lines express the interface of the inner edge of each frontal lobes on either side of the falx. The second median marker is the third ventricles, which is a little wider on its anterior portion. The third marker is a mesencephalon, or future sylvius aqueduct, that is best seen if the section is slightly tilted back. The déplacement of the probe in the frontal plane make it possible to successively control the middle level of the face, the brain, and the cerebral trunk. Here we have the alignment of the thalami and the three floors of the trunk. If the probe is slightly tilted backwards, the outline of the nascent cerebellum can be seen. Here are sagittal slices between 11.5 and 12 weeks centered on the midbrain, whose evolution is rapid. At 13 weeks, most of the brain structure are present. We can make a connection with this anatomical diagram. Stepped cross-section allow to recognize its main components. Close to the BPC side, we have the mesencephalon, little lower, the primer cerebellar. Closer to the base of the skull, the fourth ventricle, limited back by its own choroid plexus. And more vertically, the future pons, and behind the fourth ventricle and the cisterna magna, which are separated by a veil too thin to be visible. A little digression on the face in the late first trimester to illustrate the capacities of these probes. At 12 weeks, the maxillary arch above, below the mandible with this Gothic shape. At 15 weeks, the posterior edge of the palate and the soft palate. At 17 weeks, the maxillary arch and the dental alveoli. Below, the mandible whose shapes becomes Roman. We can see the uvula, odontoid process, and laterally, the parotid glands. Regarding the spine, from 7.5 weeks, we can identify a spinal axis from frontal view by rotating the probe from the sagittal view, as you can see here. The medullary canal is bordered by two echogenic lines, and the segmentation can be guessed. A slice more tangential to the skin shows a single echogenic line. At 8.5 weeks, the medullary canal is more clearly visible. We see here the spine in a frontal plane from the brainstem to the terminal part of the spinal cord. The central echogenic line is the ependymal duct. These stepped views are not achievable vaginally. In the late first trimester, the end of the medulla is located at the level of the sacrum. Finally, a situation where high frequency helps. This fetus is head up, and the patient's BMI is 31. First point, the image looks unusual, because the choroid plexus is not in the right place. In a normal situation, the choroid plexus is centered on the median axis. So there is a posterior lift of the plexus. Second point, the midbrain seems too posterior. In this reference image, we can see that normally the fourth ventricle is between the brainstem in front and the cisterna magna behind. In this fetus, these two liquid images have disappeared. The brainstem is also tilted back. Third point, the BPD is too small compared to the CRL. We expected 24 millimeter. In addition, there is an angular aspect of the thalamo-peduncular junction and a rectitude of the shape of the frontal bones. These signs are clearer with the HF. Deformation of the frontal bones, two posterior position of the plexuses, posterior displacement of the brain stem on the midbrain, deformation of the cerebellar lobe, early banana sign, and finally, the relatively discrete primary lesion in the sacrum. So in conclusion, the use of suitable high-frequency probe is possible transcutaneously. This device can be useful when the vaginal route is limited due to an unfavorable fetal position or a region of interest too far from the probe. The fact of not being blocked in the vaginal cul-de-sac allows for a more cutting plan in space. Of course, this access route is limited in case of obesity of insufficiently inverted uterus. Thank you for your attention.
Dr. Mark Althuser, thank you very much for this lecture. It was full of very interesting and didactical images to assess central nervous systems on the first trimester with high frequency probe. It was really interesting. Please place your question on the chat of the platform and we will be happy to submit them to Dr. Althuser for a reply. Thank you very much for joining and we look forward to seeing you all on the other Fujifilm Healthcare webinar we organize for ISUOG. Thank you very much.